Welcome to my brachial plexus presentation. My name is Rachel Messer, and I made a cross-stitch representation of the brachial plexus that I'll be presenting today. So to start off, the brachial plexus originates at the spinal cord, at the neck, and branches off from C5 to T1 vertebra. From there we have 5 sections of the brachial plexus. We have the roots, trunks, divisions, cords, and branches. A good way to remember this is Robert Taylor drinks cold beer. So from the vertebrae, we have the roots section. So C5 and C6 roots come together to form the first trunk. C7, its root has its own trunk. C8 and T1 roots join together to form the third trunk, and we have the upper, middle, and lower sections of the trunks. From these 3 trunks, we have 2 divisions. So we have the anterior is the dark green and the posterior is the light green. From these 2 divisions, we have 3 cords. So we have the lateral, posterior, and medial cord. From these 3 cords, we have the 5 main nerves. So we have the musculocutaneous, axillary, radial, median, and ulnar nerves. And these 5 nerves innervate the shoulder, elbow, wrist, and hand. You also may notice that we have little branches branching off of the different sections of the brachial plexus. So these roots on the C5, or these nerves at the C5 root are the dorsal scapular nerve and the contribution to the phrenic nerve. At the trunks, we have the suprascapular nerve and the nerve to the subclavius. Divisions, we just have the anterior-posterior sections. The cords, we have the lateral pectoral nerve, and then at the posterior cord, we have the lower subscapular nerve, lower codorsal nerve, and the upper subscapular nerve. And then at the medial cord, we have the medial pectoral cord nerve, medial brachial cutaneous nerve, and the medial antebrachial cutaneous nerve. So the brachial plexus is important to understand right now as students, but also as future OTs, because it's complex to diagnose in patients because there are so many nerves that branch off from the brachial plexus that can cause different symptoms in the patient and can be just hard to diagnose from those different symptoms, which may be pain, loss of sensation in the fingers or the elbow or the upper extremity, muscle weakness, and paralysis of one of the muscles of the upper extremity or all the muscles of the upper extremity. While I was working at a hand therapy clinic, I worked with a patient who had radial nerve palsy, which the way that his mechanism of injury was he fell asleep with his arm kind of wrapped around the back of a wooden chair, and the corner of the wooden chair was compressing the radial nerve at his armpit, right where the radial nerve branches off from the brachial plexus. And when he woke up, he wasn't able to extend his wrist up. So he had what was known as a wrist drop once he woke up because of that prolonged compression of the radial nerve, and the radial nerve works with the wrist extensors. So when he came to therapy, some of the OT interventions were electrical stimulation on the extensor muscles. So they hooked up the electricity to then simulate that muscle contraction and to help promote the nerve connection between the muscle and the nerve. And also they did some really light wrist strengthening, kind of assisted with the other hand to try to keep that muscle strength and try to prevent that muscle atrophy while the nerve was healing. And another common way that patients might experience this radial nerve palsy is if they have a ankle or knee injury and they're using crutches. So that constant compression of the top of the crutch in their armpit may cause some numbness or tingling within the hand or thumb and that extension of the wrist and the hand. So overall, the brachial plexus is important to understand because of there's the complexity of it and the many tests that patients might also have to go through, nerve conduction studies, MRIs, CT scans to officially diagnose a brachial plexus injury. Thank you so much for listening. Have a good day.